Welcome to another live stream on the Ultimate Fertility Guide. You're watching this on the Fertility Podcast and the Ultimate Fertility Guide, and I'm Natalie, your host. If you haven't been listening to the Fertility Podcast and you've just found this stream, then the point of it is to give you as much useful information as you can about fertility. Now, if you're watching this on replay, welcome. Do feel free to share, and any questions that you want to put, do put in the comments below. So the point of the Ultimate Fertility Guide is to enable you to find out information about the fertility industry. Having been a former patient myself, I know that it's really overwhelming when you're looking for information. There's a lot out there, and that's one of the reasons why I started my podcast. The point of the guide is I'm trying to put all areas of the fertility industry in one place. So if you've already started treatment and you now need a donor, there's sperm banks, there's clinics that offer egg donation, maybe you're wanting to travel abroad, which is why my guest today is going to be of particular interest to you. The guide is meant to be a place where you can find out the next step that you need to take. And what I'm trying to do as well is invite all the members of the guide to come and talk about their services. So without further ado, I'm going to welcome today's guest, Dr. Raul Olivares from Barcelona IVF. Dr. Olivares, welcome to the Ultimate Fertility Guide.
Thank you for inviting me. It's a pleasure.
Now, we have a heat wave going on here in the UK at the moment. So normally I'd probably be saying, oh, I bet the weather's beautiful with you, but it may well be hotter here. Do you know how hot it is with you? Late 20s?
Yeah. No. Here, you mean the age of the first baby?
No, I was just asking about the weather. I was being very British.
The weather is probably as wonderful as the one you have over there, because I know that it's quite hot now in
Yes,
UK. It's
very hot.
a heat wave, you know.
We're very lucky. So let's talk a bit about Barcelona IVF. Tell me how long the clinic's been there. I mean, it's a really impressive looking building, which you can just see the top of the dome above Dr. Olivares' head, because I've laid the picture behind him. Tell me a bit about how long the clinic's been there.
Well, this project was launched like 7 years ago. We were all working in a really big clinic here in Barcelona. We decided to start a different project with the same quality, with the same pregnancy rates, with the same state-of-the-art laboratory, but with really the big difference, which is the way we follow patients, focusing on really individualized treatments. It's like we wanted to combine new trends with old school medicine, in which you have your doctor who follows you, who goes with you throughout all the treatment, because I think that that's really very important nowadays.
And why is it that Spain can be more competitive? I mean, we have issues in the UK with clinics across the UK offering different prices. How come you can be competitive?
Well, the thing is, well, probably life is not as expensive in the UK, which is something that helps, you know. And probably in UK you feel the same when you hear the cost of the IVF in the United States, which are really far more expensive than those that you have there. But the thing is that we have a really good cultural background, in the sense that people is willing to donate. We have a lot of donors, and based on that, well, we have been able to grow and become really, really competitive.
Because I'm right in saying your egg donation program, there's no waiting list. Is that right? Or is
Yeah,
that just across the board?
yeah, no, right. We have like 200 donors, which are available right now, but we can work with a pool of more than 500 donors that if we need to call any of them specifically, they should be able to start really soon the treatment.
And just explain a bit about, if people are coming for donor treatment, the difference in the anonymity rules if you're having treatment in Spain compared to what happens in the UK.
The thing is that the egg donation is under the same regulations that any other organ transplant, organ donation. Okay, so that means that the donor becomes or should be anonymous. Our law considers that girls and men are donating cells, because they are donating oocytes or donating sperm, not babies. And then based on that, we have the same regulation. So that means that all kind of egg and sperm donations are completely anonymous. We can share some information about the donors, general information like physical traits, blood group, age, uh, hobbies, traits of personality. This is information that we can share with patients. And identity can be revealed in very exceptional circumstances. Like, for example, if there is any kind of life-threatening condition in the baby that makes necessary, let's say, a bone marrow transplant, and there are no donors available, patients can contact us and we can ask the donors if they are willing to undergo the test. But there are really very, very few exceptions to that.
Okay. So let's just talk about some of the different treatments that you offer. I mean, across the board, kind of standard fertility treatments. You've got great success rates with regards to transfers at blastocyst. But something that I feel a bit stupid for not knowing more about is roper treatment. So just talk me through that. This is a treatment for same-sex couples, for lesbian couples.
But in fact, if we talk about blastocyst, it's a treatment that you can use in all kind of treatments because blastocyst is focused on selecting the best embryo and
Sure.
therefore carry out an elective single embryo transfer to reduce the multiple pregnancy rate. I mean, this is what we're looking for, what we're aiming for when we do blastocyst transfers. And that the reason is because the most critical day for the embryos is day 4 to day 5. Okay, so this is when most of the embryos get blocked. So if you transfer day 3 and the patient does not get pregnant, you're never going to know if it was a problem of the embryos or if that couple had really lovely blastocysts that didn't implant. And this may take us to two different complete roads. Okay, so if you want to be sure about the real quality of the embryo, the recommendation would be always taking embryos to day 5. And of course, to do that, you should be, or you have to be completely sure that what happens in the lab is what would have happened if the embryos have been transferred. So you have to do your controls and be sure that the evolution, the development of the embryos is correct.
Now, obviously, the ideal is to get to blastocyst,
Mm.
and there can be quite a lot of expectation on it,
Mm.
can't there? If people go through treatment and then they're told that they haven't got any embryos that have got to blastocyst. So how do you manage expectation then?
Well, the thing is that even when we don't get blastocysts, we gather really useful information about the real condition of that couple. Okay, so the thing is that I don't think that it could be fair to transfer embryos just because you don't want to deal with having no blastocysts. Getting no blastocysts is also important because it could mean that there is an issue with the egg, an issue with the sperm. So you have more information and you can recommend tests or you can change things in order to try to fix that. But if you just miss that information because we're afraid of running that risk, so the thing is that, well, expectations is or either you get blastocysts and you can have a lovely transfer, or we're going to get a really useful information that is going to let us help you.
So would you not do a transfer if they hadn't reached blastocyst?
Absolutely, yes. I mean, the idea is to carry out the transfer only we think that there are really nice chances of success. Of
Okay.
success.
Let's just talk a little bit about Roper, which I mentioned just before. Explain it because I hadn't heard about it before. I was just looking at the different services that Barcelona IVF offer.
Hmm. Well, ROPA it stands for uh, Spanish words. Probably in UK you may have heard the concept of reciprocal IVF.
Okay.
It's more common over there. Basically, is a treatment amongst lesbian couples in which both girls want to take part in the process. So one acts as an egg donor, and the other one is as a recipient. We stimulate one of the girls, we get the eggs, we create the embryos, and then in the meantime, we prepare the other girl to receive these embryos that we create. So it's like an egg donation, but within the same couple. And it's getting really, really um, very famous, and we are getting more and more girls that are requesting that.
It's amazing. I'm just going to go back a step to we were talking about blastocysts, and I just want to say hello to Emma, who's joined to say we didn't go to blastocyst and we had a transfer on day 3. Emma, just in case you missed, Dr. Olivares did say that the ideally, you know, the treatment will still carry on even if you haven't got to blastocyst, wouldn't it? So not, we don't want to cause any panic if people are currently in the 2 week wait having, you know, transferred embryos that hadn't gone to blastocyst.
Hmm. I mean, I think, again, I mean, the information or the main issue about blastocysts is that you avoid unnecessary suffering for the couples. In the end, the negative is going to be the negative, and it could be as hard as getting a negative, getting no embryos. The difference is that if you don't do blastocysts, if you have a negative, you've missed important information about the embryos, so you may recommend repeating, or you may be not doing the right test. If we don't transfer, at least we know that there is no issue with the uterus, with the implantation, that the problem is in the embryo, and then we can do some tests to try to find out what's going on there.
Okay. If you've just joined us, I'm talking with Dr. Raul Olivares from Barcelona IVF here on our live stream with the Ultimate Fertility Guide. You're either watching on the Fertility Podcast Facebook page or the Ultimate Fertility Guide Facebook page or on replay. So if you are watching on replay, it's good to have you here. Make sure you watch the next one. So I have had some questions through already, Dr. Olivares. Alison says they're about to start a fourth round of ICSI. However, her egg quality isn't great. She said her AMH is at the right level, but her egg quality isn't great. Any advice, any vitamins she could take?
Well, the thing is that as it happens most of the time in reproduction, the most important data is the age. Because sometimes, obviously, as women get older, the age plays a very relevant role in the quality of the eggs. So the advice will be completely different if this girl has 32 or if she has 42, because unfortunately, as they get older, there is nothing that we can do to improve the quality of the eggs, unfortunately, or very, very little and very controversial. So when we have a real oocyte problem and the girl is over 40, we tend to move more to egg donation rather than spending time. Also, the main problem with the vitamins and things like that is that sometimes they have proved that they can improve the quality of the sperm or that you may get slightly better eggs, but never have proved to increase the live birth. And what we want are babies, not sperm and eggs. And this is sometimes the main controversial. So they may help to increase the natural fertility, but once people are doing assisted reproduction, the usefulness of this kind of treatment, and obviously when the woman is over 40 or when there is a really severe male factor, they are not going to help very much.
Okay. Okay, Diane says, what is the best treatment for unexplained infertility? By that, I mean tests ahead of starting treatment.
Well, here again, it depends a lot on a lot of conditions. First, the number of tests that they've had. For example, in my experience, we cannot talk about unexplained infertility if we have not done some kind of genetic tests on the sperm that are not usually recommended. And it seems that once the man has a normal spermiogram, it's like he's fertile and everything's okay. And sometimes it is not like that. Again, it depends on the age. I am going to insist a lot on the age of the woman, but unfortunately, is the key factor most of the time. So, in cases in which a woman are younger, I would say younger than 35, considering IUIs and a course of 3 IUIs would be a good start. And once we start thinking that there could be a problem with the egg quality, especially when women are over 35, in most of the cases we may recommend start with an IVF. The IVF itself, sometimes it is a diagnostic test because it allows us to check the quality of the eggs. There is no other way of knowing the real quality of the eggs. It also shows us the fertilization rate, the embryo quality, how many embryos, and this can sometimes help us understand what's going on inside.
Am I right just on that IUI point? Because I've heard that there aren't great success rates with IUI and that you wouldn't say more than 3 attempts at IUI.
The only exception, I mean, yes, we know that during the first 3 IUIs, the pregnancy rates are very similar, whichever they are. So they are not going to change. But once you go beyond that third IUI, the pregnancy rates start to fall down. The only exception to this probably would be cases in which you are doing IUI in non-infertile patients, like single women or lesbians, in which you may go up to 6 attempts.
Wow. Okay.
In the end, if you had a couple in front of you saying that we have been trying to conceive for 3 months, probably what would mean 3 IUI, we are talking about non-infertile couples, you would push them, say, okay, try to be patient and keep trying for it, you know? So it's different when you have a patient, a couple who have tried to conceive for some time, and when you have someone who has had no opportunity to conceive, you have to be a bit more conservative in this sense.
Tony has says we've been thinking of coming to Spain to use an egg donor. Can you explain how the process works?
Well, the process has become really very easy. First, because we are now doing a lot of appointments through Skype. So we
Okay.
can even get the first visit at home. They don't have to come here. And then we work with fresh eggs. That means that we synchronize the cycle to the patient to the cycle of the donor. And we do that putting both women in a contraceptive pill. Then we make both stop the pills at the same time. They get their periods roughly at the same time then. And once the donor has that second period, starts stimulation, and the recipient starts the HRT that is going to prepare the endometrium for receiving the embryos. Okay, then the recipient has to have a scan in her country to be sure that the thickness of the endometrium is okay. That it should be at least 6 millimeters. And if it is, we wait until the day of the donor pickup. We collect the eggs. We may work with a fresh or frozen semen sample. Results are exactly the same, no differences. And then we inseminate the eggs. We create the embryos. 5 days later, we transfer them. So the whole process from day one of the synchronization till the day of the embryo transfer should take no more than 5-6 weeks. That's it.
And obviously, with the flight to Spain being so short, people can come and go with a fair amount of ease. I mean, what kind of so if somebody's coming for egg transfer, what would you advise that they to kind of come and they stay for?
The day before to avoid last minute issues because the process is already stressing. So we don't want to put any extra stress on the patient. And then they usually, in normal conditions, in the normal egg donation cycle, they come once to freeze the sperm sample and do some tests that may need, especially if they want to do what we call the genetic matching between the man and the egg donor. And then if they freeze the sperm, they only have to come on the day of the embryo transfer. They come the day before, we do the embryo transfer, and the next day they can fly back home completely safely.
Wow. Because I remember when we had our transfer, I was adamant I wasn't going to get on an aeroplane, but I know that it makes absolutely no difference, does it?
I have patients that fly back the next day to the United States, China, Singapore, and they get pregnant. So I'm not really concerned about. And even when we do cryo transfers, I have patients that land in the morning, have the transfer, and fly back in the evening.
Wow. Okay, just get on with it. Okay. Catherine has said, "Do you have any age restrictions on using donor eggs? I'm 42, but with a low AMH of 7. Any tips to make it work?" I know we mentioned about AMH before.
Well, no. I mean, the only age restriction that we have is 50. So we can treat patients until they are 50. Once they are 51, we don't treat them. So that's the only. And it's true that once the patients are over 45, we usually request some information from her doctors just to make sure that they are healthy, that getting pregnant is not going to mean any unnecessary risk for them. But that's it. As long as they are healthy, the only age restriction is 50.
And I suppose if somebody's coming, especially if they're coming alone and they're in their 40s, and this is obviously a kind of last attempt, is there counselling available to just if there's any emotional kind of, well, there's obviously going to be emotional concerns. What kind of support do you offer?
Yeah, we do. We have our own psychologist who is very expertise because she's working in this field for more than 15 years of this moment. So whenever they have to struggle with anything negatives or even the donation, and we put a lot of effort on that. In fact, we are now carrying out an interesting study in which we have like 10 questions that we give to patients before they start the egg donation treatment, once they are pregnant, and when the baby is 1 year old. And you see how the approach completely changed in some questions. So this is something that is allowing us to learn a lot of things of how do we have to manage this stressful condition in treatments.
Okay. Because I like to put a big emphasis on that emotional support. And I think when you're adding going abroad for treatment, it can be quite daunting. And Amy has asked, can my clinic get in touch with you and work with you? And I think that that's something that is really kind of key with people in the UK if they are considering coming abroad for treatment, but they've already started some level of investigation, is how that crossover process works.
I mean, the idea, as I've said before, is that we want to change the way we are treating patients. With the new technologies, it's very easy to get in touch. So the old approach of having to open our own clinic in UK or in Italy or in France because we treat patients from across Europe, I don't think that is valid anymore. I mean, it's much easier that patients get in touch with us, and then we can get in touch with their doctors, and they are our doctor, our local doctor. So we always willing to collaborate. We Most of the diagnostic tests, more of the control that they have to do, not just in egg donation, but even in IVF. They are doing the scans in their countries. They send the reports. We assess them. Then we tell them how to continue. How to continue. And the fact is that more and more often, my first meeting with patients of IVF is on the day of the collection. So we've had a lot of contact through emails, Skypes. We have been in contact with the clinics, the doctors, and then everything is done there. So just trying to keep it as simple as possible.
Okay. I've had a question from Finola who says, are there any restrictions with regards to BMI?
Well, I mean, restrictions, probably I would not recommend to undergo a treatment once the BMI is higher than 35. Okay? The reasons are basically that the implantation rates tend to be lower and the miscarriage rate tend to be higher. And of course, the idea is that since we are going to be part of this process of helping someone to get pregnant, what we want is to be, or what we want that patient is to be as healthy as possible. Because it's not like, oh, I'm just pregnant and I can't do not know. We are doing some active process to get pregnant. So not just the BMI, but the vitamin D, folic acids, a lot of things that should be taken in control. And of course, the healthier the woman is when she gets pregnant, the better the pregnancy is going to be.
I mean, I talk about how you want to really be match fit before you go into this because it is a really exciting process. With the ultimate goal being that you do get pregnant if you're the female, or as a couple, you know, you do get to take home a baby, and so you want to give yourself the best choices. And I think you have to approach it without putting too much pressure on it. If you do need to lose weight, try and work through things that work for you and ask for support. I mean, I'm sure you offer guidance on that nutritional
Absolutely.
side as well.
The only problem here, and this is something that we try to fix, is that sometimes patients don't have much time, okay? Because when you have a 30 years old girl with a really high BMI, you can invest like 6 months, 1 year to try to reduce the BMI. But if you do that when the patient is 41, what could have been an IVF would probably be an egg donation, okay? So you have sometimes to be careful. In these cases, our recommendation is that despite knowing that when the BMI is high, sometimes the ovarian response is not as good as when you have the right condition. In cases in which time could be critical, we recommend doing IVF, freezing the embryos, and then taking the necessary time to get the right conditions for getting the transfer.
Okay. Now, you mentioned miscarriage before, and I had a question from Suzanne saying, what tests would you suggest ahead of treatment following our first cycle ending in a miscarriage?
Well, Unfortunately, I have to say that having a miscarriage is not such a strange thing, you know. In infertile couples, the miscarriage rate could be as high as 20%, and in IVF it could be even higher because of the basic conditions. We have just presented a study in our National Fertility Congress that shows that after the first miscarriage, the pregnancy rate in the following treatments do not change, are exactly the same. So I would recommend some special tests probably only after a second miscarriage, not after a first one, unless there is any risk factor that we can identify or that we're thinking of. But if it's just a miscarriage and everything seems to be okay, probably my recommendation would be consider a cryotransfer before starting with more complicated treatments like heparins or thrombophilias or immunology, which is a very controversial issue.
You said a cryo transfer. What's that?
Cryotransfer is sometimes when you get an IVF or an egg donation, you have your fresh embryo transfer, and then we can freeze embryos.
Oh, I see.
Okay?
You mean a frozen. Yep.
And then the frozen is a cryopreservation, cryotransfer.
Yep. I get you. Okay. We've not got much time left, so I'm just going to share the information about Barcelona IVF, their website, and where you can follow them on Twitter. And Dr. Olivares, I'm sharing a picture of an embryo scope. Do you want to just explain what the embryo scope does?
Well, the Embryo Scope, or in general, in more general, the time-lapse technology, because Embryo Scope is a brand,
Yes.
okay, is the closest to the uterus that we have in the lab right now, because it's an incubator that has a camera that takes a picture every 15 minutes, and this has two main advantages. One is that we don't have to stress the embryo, taking them out to assess their quality, exposing them to light, temperature changes, and things like that. So we just leave the embryos there 5 days. And on top of that, with these pictures that we take, we can make a time-lapse video, okay? And this helps to decide which is the embryo that we are going to transfer, because it is not just that the embryos are pretty or not on day 5. We just can go back and see how the embryos have divided. So we are adding some extra functional information about the quality that allow us to increase by a 7% the pregnancy rates compared to the traditional incubators.
And without wanting to be controversial, because in the UK there's a lot of emphasis on add-on treatments. Is this something that is standard in your treatment, or is this considered an add-on if people are considering coming to Barcelona?
Probably makes more sense in cases in which you don't have too many embryos, okay, and you want to really take care of them. Because if a couple or a girl or a woman produces like 18 eggs and they have like 16 embryos, if they will lose 3, 4, well, the outcome is not going to change. But if you really are worried about the quality of the eggs, or you don't have too many eggs, we have noticed that even in cases in which there are like 3, 4 eggs retrieved, you can get one more embryo, and going from 12 to 13 may not make a big difference, but going from 2 to 3, it could be a huge difference.
Okay. Well, before we say goodbye, Dr. Olivares, just your last chance to sell Barcelona IVF to us.
Thank you very much for inviting me. It's a pleasure, and whenever you need me, here I'm going to be.
Just give me your last kind of reason as to why people should come to Barcelona IVF.
Sorry.
That's
Sometimes
okay.
it's like a big cut in the connection. I'm not here.
Sorry.
Well,
that's okay.
No, that's okay. That's okay. That's technology. So the thing, well, I mean, I don't pretend to be the best clinic in the world in terms of results. We really have very good results. We try to do our best probably to help patients. And if there is any really nice difference with other clinics, is in the way we follow patients. I mean, if you come and you are visited by me or by any of my colleagues, you're going to have the same doctor throughout all the process. You always have the same people talking to you, telling what you have to do. And this helps to really build a really strong relationship of confidence that is quite reassuring for patients, you know?
Yeah,
So
definitely.
more about quality, especially in terms of care, that obviously with results, because if you don't get results, you know, there's nothing.
Thank you. Now I'll let you go. Thank you for your time. It's been lovely chatting to you.
Thank you very much for inviting me. It has been a
Thank you. Thank you. Now, next time on the Ultimate Fertility Guide, we are going to be speaking to Gail Sexton Anderson, who is the founder of Donor Concierge. Now, this might sound familiar because I did try and speak to Gail previously, and the sound quality was pretty poor. Technology failed us. So, Gail will be back talking about Donor Concierge. If you're thinking of working with a donor, she will be answering all your questions. Do make a note of the time. If you have a look at the Ultimate Fertility Guide Facebook page or the Fertility Podcast Facebook page, all the details will be on there, and we look forward